Thank you all for joining us today for another one of our Meet the Specialist sessions. These have proven to be a really valuable way, a short snapshot for you to see who our specialists are, what they do, and get an idea of what they're like and what they're all about. And today we have the very lovely Associate Professor Chris Alderman, who is a clinical, well, he is a pharmacologist, but he has a special area of expertise in the clinical pharmacy associated with psychiatry and a general focus on safe use of drugs. So without further ado, I'll hand over to you, Chris, to talk a little bit about what you do in the medico-legal space and who you are. Thank you.
Well, look, thank you very much, Michelle, and thanks to everybody who've taken the time to come and be here today. I know it's we all have busy lives and there's plenty to do, so I appreciate people taking time to come and listen to me. So look, the kind introduction I got from Michelle there tells you a little bit about what I do, but I am trained in pharmacology. I also have training in psychology as well and in counselling. They were my three undergraduate disciplines. My doctoral training was about the safe and effective use of medicines, and in particular with reference to the adverse effects of medicines and the way in which they behave when used in large groups of people. That's a science called pharmacoepidemiology, which is also an interesting but different kind of discipline. So I do quite a lot of work in the medico-legal space these days, and it seems that there's not a lot of people who are working in the area in which I work. So it seems that work comes in for me from all over Australia, and in fact, not only Australia, but other parts of the world at times. And it's quite specialised work. So I thought I might just spend a few moments running through with you a little bit about, the sorts of things I routinely get involved with. And I thought, if it's okay with everybody, that we might use just a couple of slides. I'm not going to bore you with a long slide presentation, and I promise no jokes. I've told my children I'll lay off the dad jokes for a bit. But I do have a couple of slides. So just bear with me for a moment and I'll see if I can do this. Host is disabled screen sharing, so that's put paid to that, Michelle. Don't know whether there's any way to enable screen sharing.
I've just made you co-host, so you should be able to do that now.
That sounds very important. I'll try now that I've been made a co-host. There we are. This is looking good. So let's just see whether or not I can find the right slides. This looks it. Okay, so I'll go with that one. Can you all see a slide presentation there?
Yes, we can.
Okay, so you can see one that says assessment.
Yep.
Okay, so this is effectively a summary of the sorts of things I get involved with in the medico-legal space. And I just wanted to make a few preliminary comments, because these are really quite important to emphasise. But so in general terms, I conduct my reviews either in person, which is what I prefer to do if I can, or by way of file review. I can do the in-person interview either live or virtual. So, and there are a couple of ways of doing that. So I can either come to you if it's not in South Australia, or I can do one in South Australia if it is somewhere in South Australia. So that's one way of doing it. Obviously, if I'm traveling, it probably makes sense to have a number of them lined up, but that does sometimes happen, and I have made trips specifically for that purpose. So they can be done live in an office, and that offers a range of advantages. They can be done virtually using something like Zoom, Teams, or Blue Jeans. There are different systems that can be used for that purpose, and I'm happy to do that. It means, of course, that if I am doing it virtually, then there are certain things I will rely upon others to help me with in terms of, for example, weighing the client, measuring their height, taking their blood pressure, their heart rate, those sorts of things, those basic observations. Nothing too terribly detailed, but it just requires a bit of working together to get that done. If I can't do that, then I will note that I am unable to do it, and that will be, I guess, an area where there's a bit of a gap in the report. So live or virtual in-person interviews, or by way of a file review. So in other words, a review on paper. And some people choose to do that either because the patient, the client, doesn't make themselves available for interview. They sometimes have been instructed. This is a new thing for me, but I've been told that there are some lawyers who won't let their clients see me because it damages their chances. So it's quite interesting to think that the lawyers have now decided who they'll allow their clients to be assessed by. I gather there are still ways around that if you need to get it done. And then also the file review basically can be done on paper, but it takes a lot of time depending on how much paper you give me. And that's the point I'd like to make, is that doing things from written records has some advantages because you can reference certain aspects of the file. But naturally, if I get sent 1,000 pages of notes to read, and that happens from time to time, then I need to read 1,000 pages of notes. And to do that justice, it's going to take time. And of course, time is money. So it's worth bearing in mind, if you're going to send me a file, it needs to have enough information in it to be meaningful, but not too much information that it costs your client a lot of money to get the job done, because once I've been sent it, I have to read it. And you'll be surprised, oftentimes I'll get 1,000 pages of notes, and it turns out that there's only 600 original pages, and there's copies of things and redundant information and huge tracts of irrelevant administrative data that really doesn't serve any purpose for anybody. But as I said, once I've been sent it, I must read it all, and that's the bottom line. So just, I guess, be judicious if you're sending a file to review. On the other hand, if I get sent a file review and there is critical information missing, and I'll talk a little bit about the sorts of information I need in a moment, then oftentimes, if I'm going to file a report, it will have some critical gaps in it, and more often than not, what then happens is a supplementary report is required. So it takes longer and it's more expensive to do that again. So you can see why, in many ways, a live review with an interview is preferable if possible. So the quality and the completeness of the review depends entirely upon the information that's available to me when I'm doing that. Now, the interesting thing is that really, in my field, one of the most important pieces of information is understanding comprehensively medication use before and after critical events. So in other words, before and after an accident, for example, or a workplace injury, before or after the appearance of particular symptoms that people are ascribing to the effects of medications. This is absolutely critical. So I need to know all about the medications, not what people think I need to know, or what a client might want me to know, or what perhaps someone's lawyer wants me to know. I need to know the lot. And so furnishing with me with information, for example, I'll often get sent a record of PBS dispensing, and people believe that to be the right information for me to use. What I would say about that is, it tells me, yes, that a person received a prescription and it was presented in a pharmacy on a particular day. It doesn't tell me whether that was the first day that person ever had a prescription dispensed. It doesn't tell me whether the person was actually taking that medication. You can have a prescription dispensed and not have it in your cupboard or not taking it. It doesn't tell me if you've started taking it and then you stop taking it. And in fact, it's quite critical. It doesn't tell me anything about timelines other than the actual date the prescription was dispensed. It's also fair to say that people doctor shop. They move around, so they'll present to more than one pharmacy. So presenting information, unless it's come from the Pharmaceutical Benefit Scheme, doesn't give me a full picture of where people have gotten their medications from. If you're just presenting the records from a pharmacy, there's nothing to say that person hasn't been to 4 other pharmacies in the same period of time. So that's important to know. Also, bear in mind that pharmacy records usually don't provide me with any information about the dosage of the medicine or the route in which it's being administered by. So it's important to know, you know, for example, is this 1 tablet 3 times a day, once a day? Is it 1 tablet when required? All those sorts of things. And very often that's not information that's available from a simple pharmacy record. This is why I often like to interview a patient, because with some skillful questions, you can usually get pretty quickly to the heart of what they've been taking and for how long and in what way. So I just wanted to raise that with you. I've also put in red there full medication details, and that's because you'd be surprised how people can amnese certain things. For example, if something is not something they necessarily want you to know they're taking, then they will conveniently forget to mention it or include it in the records of what is presented to you. Likewise, sometimes they completely overlook medicines which are not in oral form. So in other words, if it's not a tablet or a capsule, suddenly it becomes not a medicine. So that can be inhalers, for example, it can be eye drops, it can be all kinds of other things. So that sort of stuff is important for me to know about full medication details. The other thing, of course, is not every medication is prescribed. So sometimes they are medicines that are available on a non-prescription basis, purchased from a pharmacy, products from the health food store, products from traditional medicine practitioners. These are all relevant. So if they're taking a supplement, for example, or if they're taking a traditional Chinese medicine or an Ayurvedic medicine, there have been situations where that's very relevant. I then need to think about the hospital investigation reports, if these are relevant as well, and they can be very relevant. So, for example, the results of blood tests, imaging, microscopy and sensitivity, those sorts of things as well, can be relevant depending on the type of drug-related issues that I might be well investigating. So err on the side of being inclusive if you can. What I can then do is assemble what's called an Naranjo causality algorithm. Now, this I don't expect will mean a great deal to terribly many here, but just suffice to say that magistrates particularly like the Naranjo causality algorithm. So what this is an internationally accepted benchmark to assess the potential causality of an event. So if someone says, I have developed a blue spotty rash all over my body, then I can apply a set of parameters, put them into this algorithm, and it will tell me with internationally accepted certainty to a degree how likely it is that that rash was related to the introduction of a medication, for example. So this is particularly important, for example, in situations of secondary compensation where people, for example, have hurt their back, they've started taking medicine for their pain or their depression, and then they're subsequently claiming for other issues that might be related to a dry mouth, constipation. These are common ones I come across, weight gain, sexual dysfunction, all of those sorts of things. So it really does help lay this out. And as I say, often I find when I go to court that the judges are very interested in this because it gives them something to review and to think, well, this is not just subjective say-so of somebody, this is internationally accepted in the literature as a means to determine likely causality. I will then also put into the report recommendations for other investigations, assessment or management. So, for example, I saw a patient yesterday. He presented to me, and the matter under consideration was whether a rash was related to the effects of the medication. And in my report, I was able to say, look, the timing is such that it's unlikely but not impossible. But what you do need to do is refer this person to an independent expert in dermatology and to ask them to perform a biopsy if they're unable to produce a definitive opinion about the likelihood of this rash representing a drug rash, for example. So I will often suggest, referrals to, and the ones I tend to ask to people to be referred to are people like dermatologists, gastroenterologists, and sometimes clinical neuropsychologists if the matter under consideration is potential drug-related cognitive impairment. Other assessments, so I might say, for example, this person presents with a picture of reflux, but they've never had testing for Helicobacter pylori or an endoscopy. So I would suggest you might consider referring them to a gastroenterologist for those purposes. And sometimes I'll also make recommendations about management. So in this chap's case yesterday, he described a rash, and we explored that together. And it seemed to me that he had a rash that probably was consistent with a fungal infection on his skin. So I suggested he go to a pharmacy, get some antifungal ointment to try that to see whether the symptoms went away, and he was quite happy with that. So these are all things that come out of my assessments. Oops, I don't know what's happened here. So these are the sorts of things that I often tackle in an assessment. So I will assemble a full medication history for the patient. I'm often asked, can I highlight which medications are being used for matters that are potentially compensable and which are related to non-compensable or incidental issues. So a person might present, for example, taking 3 or 4 medications in connection to an injury, but they might also be taking unrelated medicines for their high blood pressure, for their diabetes, for their epilepsy, and so forth. I'll assess the timing relative to an event. So we want to know pre-existing use of medicines or pre-existing issues. In one particularly noteworthy case, I can recall there was a chap who was telling me that he felt that his teeth had been damaged by medicines he was taking. And I said to him, look, you'll have to clarify this for me, because it seems to me that your records indicate you had all your teeth taken out 25 years ago. And he said to me with a perfectly straight face, yes, but if I had teeth, they would have been affected by this medication. So clearly he'd been asked to assert that, and it was pretty easy to deal with what the consequence of all that was. I'll be asked sometimes to identify which medications appear to be clinically justifiable under the circumstances, and I can do that, but I have to preface that by saying I'm not the person's primary clinician, and so I'll mention things, but I'll say there could be another reason why a person could be taking a medication. I often get asked, could a medication be causing a specific adverse effect? And I'll show you some of the things that I make judgments on in a moment. Are there interactions between 2 or more drugs that the person is taking at the time? We use the rule of 5. If your patient is taking more than 4 medications, there's a very high likelihood that they will have a clinically significant drug interaction. Not always, but it's a pretty good indicator. 5 or more medications is a tipping point. I'll be asked what other reasonable investigations, assessment, or management might be implemented, and that talks to a little bit of what I was saying before. And now what I'm doing also, and I'm really finding quite rewarding, is to see people before they've developed problems. So this is in the early phase after they've had an injury, to make recommendations about preventative interventions and to counsel the patient about things that they can do to protect themselves from potential adverse effects of medicines later on down the path. So, for example, I might say, look, you've been put on a medicine that causes reduced saliva production. We know that saliva production is critical to protecting your teeth against tooth decay. For this reason, I have to stress to you, it's very important that you must brush and floss your teeth twice a day, and you must go to a dentist every 6 months to make sure we pick up any decay early in the piece before it becomes something that requires you to have multiple teeth extractions, implants, and all sorts of expensive interventions. So these are all things that I can address in reports and do routinely. And here you can see what I've done here is just to point out some of the things that I often get asked about. So people will present and say, I have, they don't use the word cognitive impairment, but I'm confused, I'm less sharp, I find I'm groggy, sedated, I'm not going as well mentally as I used to. I've become depressed. Sometimes people become psychotic as a result of the medicines, and I can identify that as well. So they are the central nervous system effects that I sometimes clarify. In the oropharyngeal cavity, the main issues are things like xerostomia, which is the medical term for dry mouth, bruxism, which is grinding of the teeth, temporomandibular joint dysfunction, that's the joint where your jaw meets the skull, and dental decay. So these are things I get asked about quite a lot. In the cardiovascular system, I'm asked to comment on heart disease, things like myocardial infarctions or heart attacks, strokes, blood clots in the legs or the chest, and obstructive sleep apnea is another one that comes up quite a lot, whether it's caused by or is exacerbated by medications. Gastrointestinal issues are quite common as well, things like reflux disease, other problems with the esophagus, dyspepsia, nausea, vomiting, diarrhea. Constipation is a big one with a lot of the opioid analgesics. Urogenital issues, things like urinary hesitancy, urinary retention, and endocrine issues such as diabetes, osteoporosis, weight gain, or erectile dysfunction for men treated with medicines over a longer period of time. So you can see here that there's a broad scope of things that I do address in the reports. Look, I've done now hundreds of these over the years, and it's quite interesting to see the themes emerge. And it's also, I think, quite gratifying for me to see that sometimes when you sit down and talk to a patient, you can work through with them and they can recognize patterns of things that did exist before they ever got their original workplace injury and things that they can do to help themselves. So I might say to a person, as I did only yesterday, a person who was injured and became depressed and was also a bit sad and depressed about the fact that she put on a great deal of weight. Look, the antidepressant that's been prescribed for you now is also known to be associated with weight gain. So what I'm going to recommend in this report is that we get you to see a dietitian, perhaps an exercise physiologist, that you buy some sort of Fitbit or fitness monitor and try and take some proactive steps to prevent this weight gain from being exacerbated by the medications that you're necessarily being prescribed in connection to your workplace injury. So don't please take from this conversation that I'm all about getting people to stop medicines, nor am I about trying to discount things from being reasonably proven to be associated with the medicines that a person is taking. In fact, just the opposite. If a person has a drug-related problem, and I believe it's because of a medication they're taking, it's in everybody's interest that they understand this, and perhaps we can think about ways in which we can address that. So that's a bit of a broad overview of the things that I do in the medico-legal space. I know we've only got limited time and everybody's got busy schedule. So perhaps I should just stop there, pause, and see whether anybody's got any questions connecting to any of this.
Terrific. Thank you so much. That was really interesting. Anyone, do you have a question you'd like to ask of Chris? You can unmute yourself if you'd like to do so.
Please don't be shy.
I have a question from someone who was unable to attend, and they were wanting to know, how easy is it to determine whether a side effect is the result of a clash of medications, and further that the determination of whether the prescribing doctor should not have prescribed a medication that could reasonably have interacted with another.
Okay, well, look, I mean, there's a couple of points to make there. One is that it's relatively simple if you approach it systematically. So knowing the time course is critical. Understanding when a medication was started relative to an event, for example, whether there were predisposing factors. And sometimes those predisposing factors can slip under the radar. So I had somebody who told me they had widespread tooth decay, and as it turned out, with a few more questions, told me also that they had been a heavy user of methamphetamine for about 5 years, which of course
that'll do it.
Definitively causes tooth decay. So it's pretty hard to pin it on the prescribed medications if there's something like that running in the background, for example. So that's one aspect of what you were saying. The other aspect of whether it's justifiable or whether a person should have known better when they prescribe medicines together, that's a much more difficult one, because you'll appreciate I'm not sitting in that doctor's place when they make that call to prescribe the medicines, and I'm loath to be judgmental about it, because these are often very difficult cases, long-standing pathology. People inherit a patient who has, a chronic pain disorder, chronic opioid use. It's never easy. So I don't make judgments about that, but you can use certain benchmarks. So for example, the Australian approved product information, which is public domain information, easily accessed, will tell you what the normal dose should be of a medicine. It will warn you of the common adverse effects. It will warn you of what we call contraindications, in other words, situations where you shouldn't prescribe a medicine because of pre-existing illnesses or things like that. And it'll warn you of important drug interactions. So I think a court reasonably holds that a doctor should be aware of the parameters of the Australian approved product information when they are prescribing a medicine for a patient.
Right. Look, one other question I have relates to something you mentioned earlier, and that was Ayurvedic medicines, traditional medicines, etc. And I'm aware of 2 medicines that fall into that category that people might reasonably take and might perhaps be a bit embarrassed to disclose that they take. And one, for example, is the Chinese herb black cohosh, which is known to be prescribed for women at the time of the menopause, for example, but is also known to cause catastrophic liver failure. And a recent case where some Ayurvedic medicines that were purchased in Australia had dangerous levels of heavy metals. Is that something that you come across?
Yes, you do come across those things, and they are not always benign at all. The other thing is that they are not always true to label. So there was a very famous case where a person was taking some very powerful anti-arthritis supplements that came from China. And when they took their anti-arthritis supplement that came from China, their arthritis symptoms miraculously disappeared. Turned out that the anti-arthritis supplement, which was said to be a herbal supplement, was full of corticosteroids, was full of powerful anti-inflammatories and opioids, and it would be a miracle if they had any symptoms at all. But it's not something you'd prescribe for arthritis. So just because it says herbal on the label doesn't necessarily mean it's herbal in nature. Sometimes it can be very much powerful medications that are there.
Absolutely.
So, and obviously also contamination and those sorts of things. So it depends, and we may well refer, for example, for a chemical analysis, and that's something that I also can do because I have links to some analytic labs which can run what we call an HPLC, high pressure liquid chromatography analysis on a sample to determine whether there are indications that there's something there more than what the label says.
Right. Look, that has been really informative, and I thank you so much for your time today, Professor Alderman. And to everyone who joined us today, thank you for making time as well. The recording of this will be available to you within a day. And of course, it will be on our YouTube channel with all our other wonderful seminars, including Chris's previous one for us. So thank you, and please join us again for our next one. Thank you for your time, and have a great rest of the day, everybody.
All the best. Thanks for joining us. Okay. Bye now. Bye-bye.